All right. Welcome back, guys. Welcome back to I think I'm affectionately calling this our quarantine lecture series for PTA 120 and 140. I know it's a little bit late in the game to come up with a quick little catchy nickname, but we are now referring these two classes as a quarantine lecture series. Okay, so now what we're doing today is talking about the ankle and foot joints from PTA 120. Okay. We have talked about the spine, we've talked about the pelvis, we've talked about the hip, talked about the knee, and now we're moving our way down to that final peripheral joint complex, the ankle and foot. Okay. So much like the wrist and hand, things can get a little bit squirrely when we start talking about the palmar surface of the foot and kind of all the muscles that move those toes in and out, all the little bones, all of our tarsals, our metatarsals, and our phalanges. And so if anything starts getting confusing, just again, please write it down and then be sure to kind of get my attention during lab and we will discuss things because I'm sure many of you will have other questions as well. Okay, so we're going to start kind of at the most proximal area with the tib fib and then move our way down. Okay. So the leg extends from the knee to the ankle, right? That consists of the tibia, the fibula, and a strong interosseous membrane. Okay, so where's the other aspect that we have an interosseous membrane? Hopefully you are thinking in between the radius and the ulna. Okay, so it's not all that too different from the arm or the lower arm. Okay, that interosseous membrane keeps the two bones together, and it also provides greater surface area for muscle attachment. Okay. Now, when we start talking about pathologies later, what the pathology that's most involving of the interosseous membrane is that high ankle sprain in athletics, and we will get to that later. So that's just a little bit of some foreshadowing. And there is the two grandiose bones and their interosseous membrane. So the tibia is the larger of the two bones. It is the only true weight-bearing bone of the lower leg. Okay. It's triangular in shape, with an apex or a crest anterior, right? That is the sharp bone. If you were to reach down and feel your shin right now, that is the sharp aspect of your shin bone. It's the reason why soccer players wear shin guards, right? Because that crest is sharp and painful. If you've ever been walking in a parking lot and went and walked too close to a truck with a trailer hitch and nailed your shin, you know exactly what I'm talking about. Right, the fibula is long and thin. It's set back in line and in line with the posterior surface of the tibia. It is mostly used for muscular attachments like the peroneus or the fibularis. So tibial landmarks, what we've already talked about. We've already talked about the medial condyle. Already talked about the lateral condyle. The crest is that anterior border. The medial malleolus is a distal end on the medial side. There is no lateral malleolus because that lateral malleolus is made from the fibula. Okay, so the two main landmarks in the fibula is going to be the head, which is the large and proximal end, and then the lateral malleolus, which is the enlarged distal end. So if you've been involved with any type of athletics or anything like that, you know that the ankle has two malleoli. It has a medial and a lateral. And what's interesting is that those two aspects are made up of different bones. It is not just one bone that makes up the medial and lateral. The medial is on the tibia and the lateral is on the fibula. Just a simple picture of the two landmarks with all the landmarks that we've talked about. And we're going to move into the tarsal bone. So these are everything that's more distal to the tib fib. The calcaneus is the longest and most posterior. And that's your heel bone. If you were to jam your heel on the ground right now, that's what you would be hitting is your calcaneus. Then we have a calcaneal tuberosity, which is the projection on the posterior inferior surface of the calcaneus where the Achilles tendon will insert upon. We have our sustentaculum tali. That's a fun anatomy word. Okay? Our sustentaculum tali is on the medial superior part. That projects out from the rest of the calcaneus that supports the medial side of the talus, and it also has these three tendons that loop around it. Okay, and we'll get into this when we talk about the muscles themselves, but The 3 tendons that loop around it are going to be our Tom, Dick, and Harry. Okay, and those are acronyms for the 3 muscles. We will get to it. Okay? And that is where it is. And we will palpate this on ourselves in lab. So this picture is a wonderful picture. We're going to see it a couple of times. So this is the calcaneus. That's what we just talked about. There's our septum tactum tali on the medial aspect of it. And the calcaneus is kind of our biggest tarsal bone. It's kind of the one that gets all the limelight. Okay? So we have our tarsals. We're going to get through all of those in just a minute. Then we have our metatarsals and our phalanges out front. So if you want to think about this, we're going to hear, especially when we start getting into gait, you're going to hear me say that this is the rear foot, this is the midfoot, and this is the forefoot. Okay? So kind of where these bones kind of transfer to from a tarsal to a metatarsal, that's going to be the midfoot, and then that ball of your foot's going to be your forefoot. Okay? So our talus sits on the calcaneus. It's the second largest tarsal bone. Then we have our navicular, which is on the medial side in front of the talus. It's going to be proximal to the 3 cuneiform bones. And our tuberosity of the navicular is our tuberosity that is on the navicular. And this is kind of what we will measure our arch height from. Okay, this is a projection on the medial side of the navicular bone, and it's easily seen on the medial border of the foot. If you have super flat feet, okay, there's times when I've seen people's navicular sitting flat on the ground because they're so far pronated that navicular, that's usually at the apex of your arch, is just sitting on the ground. Okay? And then our cuboid, which is on the lateral side of the foot, and that's proximal to the 4th and 5th metatarsals, and that's going to articulate with the calcaneus as well. So if we go back to our handy dandy little chart on the previous slide, okay, so our talus is going to be that bone there. Then we have our navicular with our navicular tuberosity. We're going to talk about our cuneiforms here in a minute, but those are going to be our 3 cuneiforms and our cuboid. Okay? So our talus is what articulates with our medial and lateral, our tibia and fibula, and then that articulates with the calcaneus. We have our other tarsal bones up more distal. Now we're going to talk about those cuneiforms. There are 3 in total, named first through third. Pretty easy, with the first being the most medial. Okay? And then first is the largest of the 3. Okay? And these are going to articulate with the first through third metatarsals. And speaking of metatarsals, here we are. Okay, so our metatarsals, just like our digits, are numbered 1 through 5, starting medially going laterally. 1st and 5th are weight-bearing bones because of our arches. We're going to get to that in a minute. And weight is borne from the base of the calcaneus to the heads of the 1st and 5th metatarsals through our arch system. Okay, so our 2 main weight-bearing components of our feet are going to be the calcaneus posteriorly, and then the heads of the 1st and 5th, not 1st through 5th, the 1st and 5th metatarsals. Okay? So if you didn't have socks on and you looked at the bottom of your feet, usually your heel is going to be around your calcaneus is going to be calloused, and then your 1st metatarsal and your 5th metatarsal are all going to be calloused because those are our main weight-bearing structures of the foot. Okay? It creates a triangle on the bottom of your foot. So those are our 3 cuboids, 1st, 2nd, 3rd. And they articulate with the corresponding metatarsal. And then the cuboid articulates with the 3rd or the 4th and 5th metatarsal. So our metatarsal landmarks, we have a base and we have a head. Okay, the base is the proximal end, the head is the distal end. The 1st metatarsal is the thickest and the shortest on the medial side of the foot. And the 2nd is the longest. Sometimes people's 2nd toe will be longer than their 1st toe. Mine is not like that. The 2nd articulates with the 2nd cuneiform. The 3rd articulates with the 3rd cuneiform. 4th is together with the fifth metatarsal and articulates with the cuboid. Same thing with our handmate in our hand, right? So the handmate articulated with, or our handmate, not up here, that's our MCP. Our handmate articulates with our fifth and our fourth metatarsal in our hand, okay? So the cuboid is the same thing. Articulates with the fourth and the fifth metatarsal. Cuboid 1, 2, 3, metatarsal 1, 2, 3, and then 4 and 5 articulate with the cuboid. And our phalanges have a very similar composition to the hand. Okay? Our big toe or our great toe doesn't have an intermediate or our middle phalange. It only has a proximal and our distal. There are times when people will lose a thumb, and what they will do, they'll come down, they'll snag that proximal phalanx and the distal phalanx and plop it right on the guy's hand and on the person's hand, and they can have a functional thumb, okay, because they're structurally very similar. Okay. First digit, great toe, no middle phalange. Second through fifth, those are lesser toes, and they have 3 phalanges. The functional aspect of the foot is divided into 3 parts, like we talked about just briefly. Our hind foot, midfoot, and forefoot. Okay, our hind foot is made up of the talus and the calcaneus. That's the first to make contact with the ground in our gait cycle, and it influences the function and movement of the other 2 parts. It will unlock and lock the foot, and it's going to be awesome when we talk about gait because we will be able to see that. Okay, and not to where you can feel this on yourself. I've done it before. Then we have our midfoot, which is the navicular cuboid in 3 cuneiforms. This provides stability and mobility as it transmits movement from the hind foot to the forefoot. So depending on what position this calcaneus is in, it's going to unlock or lock these 3 cuneiforms. Okay, it's either going to raise the arch or it's going to kind of allow that arch to pronate naturally. And you're going to hear that. You're going to hear people say you overpronate. The foot is designed to pronate. Okay? It's just if that navicular flops down the ground, it's going to affect the function. Or if that navicular can't raise up and down like it functionally should, then you're going to have dysfunction in other areas of the foot during the gait cycle. Okay? The forefoot is 5 metatarsals and all the phalanges. This adapts to the level of the ground. Okay, last part of the foot to make contact with the ground during stance phase, right? Because we go heel and toe, kind of rolling over. So hind foot, calcaneus and talus. Midfoot are navicular, cuboid, and cuneiforms. And our forefoot is going to be our metatarsals and our phalanges. Okay, so ankle motions, we have plantar flexion, we have dorsal flexion, we have inversion and eversion, and adduction and abduction. So plantar flexion is movement toward the plantar surface of the foot, like you're pushing a gas pedal in the sagittal plane around the frontal axis. Dorsiflexion is the opposite, so pulling your toes up towards your nose. Okay, that's going to be the same plane and axis. Inversion and eversion run together, so inversion is raising the medial border of the foot. So it's not turning the foot in, it's where you actually raise that medial border of the foot. Okay, turning the forefoot inward, frontal plane around the sagittal axis. Eversion is the same, but it's going to be raising the lateral bar, so it's where that palmar surface is going to now tilt up. Okay, turning the forefoot outward, again frontal plane around the sagittal axis. And an adduction and abduction, this is movement in the transverse plane where the forefoot motion that accompanies inversion and eversion. We also have supination and pronation. So supination and pronation. Pronation is a hot topic word, especially in those who deal with foot mechanics and shoes, orthotics and stuff like that. Okay, so supination is a combination of plantar flexion, inversion, and adduction, where you're actually you're gonna see that swooping motion. So it's not just the inversion tilt. Okay, it's a combination of all those. Pronation is a combination of dorsiflexion, eversion, and abduction. So the feet swoop out to the side, they pronate, or they kind of evert, and then they kind of those toes come up. Valgus is a position in which the distal segment is situated away from the midline. Okay, if we're looking on a posterior view, and you will see it here in just a minute. You'll see this. Okay, so just hold on for a second. And then varus is a position in which the distal segment is situated toward midline. So just like our knee, okay, just like our knee, when we have a valgus moment at the knee or a valgus alignment at the knee, the tibia is pointed away from the midline. A varus moment or a varus position of the knee, the tibia is pointed towards midline. Same thing. Okay? So remember, where's the fibula? Fibula's here. This is our lateral side, medial side. Okay? They should all line up, or they ideally would all line up in the same direction. Okay? But if we're in calcaneal valgus, they're going to have a valgus moment. So the bottom of the calcaneus is going to point away from midline. Okay? Calcaneal varus is where the bottom of the calcaneus points towards midline. Okay? And we're going to play with this a little bit in lab and see what happens to the rest of the foot in those positions. We're also going to talk about what happens during this in lab, because all of this is normal. Okay? We want our static normal alignment to look like this, but dynamically our heel or our calcaneus does both of these. And it kind of changes the function of the foot when it's in different positions. Or it's supposed to. Some people it doesn't. Okay? Our tibiofibular joint is two joints with little motion. They do not are not part of the true ankle joints. Play a small role in proper function of the ankle, where the superior tibiofibular joint, the articulation between the head of the fibula and the posterior lateral aspect of the proximal tibia. Okay? That's going to be, this is kind of like the proximal radial ulnar joint. It's a plain joint where there's a small amount of gliding and rotation of the fibula on the tibia. You can actually do, and we'll try it, we'll do it in lab, we can actually mobilize the head of the fibula if you're having some ankle dysfunction. If that joint is too tight or hypomobile, it can cause a dysfunction within the foot mechanics. Very ligamentous to reinforce the capsule. It functions to dissipate the torsional stresses applied at the ankle joint. Okay? So if it's hypomobile and it's not moving, it's not going to be able to dissipate those ground reaction forces coming up. Our inferior tibiofibular joint, okay, that's the one at the bottom. That's syndesmosis between concave distal tibia and our convex distal tibia. Okay. The fibrous tissue separates the two bones, where the two ligaments hold it together. Most of the ankle's joint strength depends on a strong union. Our ligaments allow slight movement to accommodate the motion of the talus. So superior, very little motion. Inferior, a decent amount of motion. So the talocrural joint or the talotibial joint, well, let's go back. Let's go back to this inferior tibiofibular joint. I want you to imagine that there's the talus that's sitting up there. Okay? That is called, as it sits in that little area, is called the mortise and tendon type of joint. It's very strong. Okay? It's kind of a woodworking term. Okay? And that talus sits up in there. When that foot goes into dorsiflexion, okay, it stretches this joint here. So if there's not enough mobility, you're not going to have sufficient dorsiflexion. When we go into plantar flexion, those two joint surfaces approximate again. Okay? So if this joint is hypomobile, if that inferior tibiofibular joint is hypomobile, or it's for some reason fused or screwed together, okay, as we go into dorsiflexion, we're going to be limited because we don't have a true separation of that joint. Okay? Mortise and tendon. The talocrural joint or the talotibial joint, you'll hear them both. Made up of the distal tibia, which sits on the talus, with the medial malleolus of the tibia fitting down around the medial aspect of the talus. And the lateral malleolus of the fibula, which fits down around the lateral aspect. There's a tendon and mortise joint. Oh, look, we just talked about it. Okay. tighter in dorsiflexion and plantar flexion. So if you have a hypomobility, okay, you're not going to have as much dorsiflexion. You may not even have sufficient dorsiflexion to have a normal gait pattern. Okay? Responsible for controlling the majority of foot motion relative to the leg. It all has to travel through that joint. Okay? Our talocrural joint. Okay? Our ankle is uniaxial, a hinge joint, roughly 30 to 50 degrees of plantar flexion. 20 degrees, that's a lot. Okay? Normal is about 15. Okay? Functional is 10. When we are rehabbing people after ankle injuries or ankle surgeries, our goal is 10. 10 degrees gets you a normal functional gait. Axis of rotation is at an angle, it's triplanar. So the motion, what that means is motion around an obliquely oriented axis that passes through all three planes. Okay? So these motions are not all true within those three cardinal planes. They kind of sit at an angle. Okay? So if I'm looking down at my foot and you put two fingers on your malleoli, that's the axis. Okay? So as my foot dorsiflexes or plantar flexes, it doesn't move in a straight line. It moves in this direction. Okay? So not only is it tilted from medial to lateral, it's also tilted proximal to distal. So it's also tilted like that. So again, that foot isn't going to move this direction. Whoop. Just straight up and down. Those toes are going to go here. Okay? And you can do that on yourself. If you push yourself away from your desk, look down at your ankle, and go into plantar flexion, you can keep it just in that sagittal plane, but you can feel how it wants to go laterally and up. Okay? It's just the orientation of that true axis. With that true axis, with an open kinetic chain, we have abduction with dorsiflexion, and we have adduction with plantar flexion. In a closed kinetic chain, we have internal rotation of the leg during dorsiflexion and external rotation of the leg on the foot with plantar flexion. Okay? Because of how that oblique line of axis of rotation for the joint. Okay? Accessory movement similar to the rotation of the CMC joint of the thumb. Okay? So our orthokinematics in an open kinetic chain, we have a convex talus glides posterior on the concave tibia during dorsiflexion. Okay? So it's an anterior roll with a posterior glide. And it glides anterior during plantar flexion. The end fields for both plantar flexion and dorsiflexion are firm or soft tissue stretch. From that soft tissue stretch. We have ligamentous issues or tendons that are restricting that motion. It's not going to be soft because it's not tissue approximation. It's going to be firm. Okay? And then we have our subtalar joint. This is the inferior surface of the talus articulating with the superior surface of the calcaneus. This is a plain synovial joint, no angle of rotation or anything like that. 1 degree of freedom for inversion, eversion. So you're going to hear about calcaneal inversion and eversion. Okay? And that happens around an oblique axis as well. It's part of the triplanar confusion of the ankle. Our transverse tarsal joint, our mid-tarsal joint, is the anterior surface of the talus and calcaneus that articulates with the posterior surfaces of the navicular and cuboid. And motions link the hindfoot and the forefoot in inversion and eversion. And functionally, the subtalar and transverse tarsal joints cannot be separated. So they kind of function as one joint. Inversion and eversion describe motions occurring at both joints. Inversion is a combination of adduction, supination, and plantar flexion. And eversion Okay? That's a combination of abduction, pronation, and dorsiflexion. So it's kind of the link between the three. Our foot joints are our metatarsal phalangeal joints. These are where our heads articulate with the proximal phalanges. We have 5 joints. We have the motions are flexion, extension, hyperextension. Again, your book makes flexion, extension, flexion, extension. This is more along the lines of flexion and extension, where they raise up, not hyperextension. Abduction and adduction. You can splay your toes. You can spray your toes out and pull them in. Splay them out and pull them in. Okay? Our first MTP joint, our metatarsal phalangeal joint, is a mobile joint, 45 degrees of flexion and 90 degrees of hyperextension. That's your great toe. Proximal and distal phalange, no middle, or just has an IP joint. Our fourth and fifth joints, 40 degrees of flexion and 45 degrees of hyperextension. So I know I don't have 90 degrees of hyperextension, and I get a lot of first digit metatarsal phalangeal joint pain because I don't have that 90 degrees. Okay? Also known as turf toe when you hyperextend that first digit. Okay? Just a proximal and distal phalange, no intermediate. Okay, so it only has an IP. So those were the bones. Now we're going to move into ligaments. So we have our joint capsule, we have our deltoid ligament medially, our lateral ligament laterally, obviously. We have our arches, we have a spring ligament, a short plantar ligament, and our plantar fascia. With the wind, my garage door just blew open. Give me a minute. Hold on. All right. So our plantar fascia, just like the palmar fascia on our hand, is very tough and very hard to get through. So the joint capsule is thin anteriorly and posteriorly so that it allows all the plantar and dorsal flexion that we need. And it's reinforced by collateral ligaments on the sides. These are a group of several ligaments. Our deltoid ligament, our lateral ligament. Okay, our deltoid. This is our lateral. This is our medial because of the fibula. Deltoid ligament has lots of different fibers that all originate at the same place, so it's all one ligament. Our lateral side has our 3 main ones, and we'll get to those in a second. Okay. So our deltoid ligament strengthens the medial side of the ankle, triangular in shape, very dense, very strong, right? Because again, we need that a lot of stability to prevent those arches from coming down. Right? Apex is at the tip of the medial malleolus, and it has a broad brace that spreads out to attach to the talus, navicular, and calcaneus in 4 parts. Okay? We have our anterior, middle, posterior fibers, and deep fibers. This holds the calcaneus and navicular up against the talus, and it helps to maintain the medial longitudinal arch. Spring ligament is not part of it. Your book kind of just says our anterior fibers, and it does name them. It says our tibio-navicular ligament, our tibio-calcaneal ligament, and our posterior tibio-talar ligament. So those are the 3 main. Our lateral ligament connects the lateral malleolus to the talus and calcaneus. We have 3 main ones. Okay, we have our anterior talofibular ligament, our ATFL. This gets a lot of love with lateral ankle sprains. Okay, we'll get to these in a second. So posterior talofibular ligament, and then our calcaneofibular ligament. So our ATFL, I like calling them by their acronyms because it's easier. It's not such a mouthful. Okay, so our ATFL is a weak ligament. It attaches to the lateral malleolus to the talus. And we'll feel these in lab. They're pretty easy to separate. We have our PTFL, strong ligament, runs horizontally and connects the lateral malleolus to the talus. And our calcaneofibular ligament, or CFL, is long and fairly vertical as it attaches lateral malleolus to the calcaneus underneath it. So we have our ATFL up front, our CFL in the middle, and then our PFL, or PTFL. PTFL running posterior. And these small ligaments are going to protect us against a lateral ankle sprain. See the difference. Big, broad, thick. Okay? That medial, it's very hard to have an inversion ankle sprain, right? Because of the deltoid ligaments in its subsequent parts. That's where it goes into our lateral ligaments. Okay? 3 little itty bitty tiny ones creates a significant amount of instability. You lean on the outside of that foot and you roll your ankle outside, you're most likely going to sprain one of those. Arches, foot is in the usual point of impact with the ground, has to be able to absorb a great deal of shock, and that's what the arches do. They absorb the impact, get the ground reaction force up the leg, and then they can also adjust to changes in terrain, and they help to propel the body forward. Okay. To allow this, the bones of the foot are arranged in the arches. We pretty much stand on a triangle, what we just talked about a few slides ago, that distributes the weight bearing from the base of the calcaneus to the heads of the first and fifth metatarsals. Okay. We have 3 points and 2 arches. We have a medial and lateral longitudinal arch. And we also have a transverse arch. So there's our triangle. So our medial longitudinal arch is the medial border of the foot, running from the calcaneus anterior through the talus, navicular, and 3 cuneiforms anterior to the first and third metatarsals. Okay, our talus is at the top of the arch, and then our navicular with our tuberosity our navicular tuberosity. Okay? Our talus, like our sacrum, is shaped in a way that it looks like a keystone. Okay? It keeps that arch from falling in. The arch depresses somewhat during weight bearing and then recoils when the weight is removed. Okay? Normally, it should not flatten or touch the ground. Okay? However, if you have extremely flat feet and you pronate a ton, that navicular, that talus, will sit on the ground in weight bearing. Okay? But then, like it talks about, then during non-weight bearing, it doesn't recoil. So if you have extremely flat feet, your feet just don't function properly, and you're going to have issues. Okay? Our lateral longitudinal arch runs on the outside of the foot. It runs from the calcaneus anterior through the cuboid to the fourth and fifth metatarsals. Okay? In normal people, this rests on the ground during weight bearing. However, if you have an extremely high arch, I have seen it where the lateral longitudinal ligament or lateral longitudinal arch does not hit the ground. Okay? So our medial view, this is our medial longitudinal arch, and then our lateral view, which is our lateral longitudinal arch. Okay? And then we also have a transverse arch, which runs from the side to side to the 3 cuneiforms to the cuboid. Okay? The second cuneiform is the keystone of that arch. Okay? You can look at the different shapes and how that keeps it going in. So we have a anterior posterior, and then we have a lateral arch in there as well. Our spring ligament is a plantar calcaneonavicular ligament. This attaches to the calcaneus and runs forward to the navicular. It is short and wide, and it's most important because it supports the medial side of the longitudinal arch. We also have our long plantar ligament, which is the longest of the tarsal ligaments. It's more superficial. We're going to try and feel these as best we can in lab. And more superficial than the spring ligament. The spring ligament is pretty hard to get to. Okay? This attaches posterior to the calcaneus and runs forward to attach on the cuboid and bases of the third, fourth, and fifth metatarsals. There's a primary support for the lateral longitudinal arch. And our short plantar ligament assists the long plantar ligament. This attaches to the calcaneus to the cuboid, and it mostly lies deep to the long plantar ligament. Okay? So our arches are supported by kind of four things, okay? Or our anterior posterior arch is supported by four things. Most superficial, we have our plantar fascia. You've heard of plantar fasciitis. We'll cover it in a minute. Not a minute, probably in a half hour or so. Okay? Then we have our long plantar, our short plantar, and the most deep one is going to be our spring ligament. Okay? If you have extremely flat feet, you have stretched all of these out, and now your foot cannot get back to that functional position. So our spring ligament from this diagram is more medial, and our long plantar and short plantar are going to be more kind of in that lateral arch. Then we have our plantar fascia. This runs from the calcaneus forward up to the proximal phalanges, and it's going to act as a tie rod. It keeps the posterior segments from separating from the anterior portion. If you know what a tie rod is on a truck and why in off-road lingo it's very important because it keeps those tires up underneath the wheel wells. Okay, this increases the stability of the foot and arches during weight bearing and walking. Okay, there's a clinical application that will talk about the windlass mechanism, and we will look at this as best we can come Monday. Okay, the windlass. Windlass is a sailing term. Again, we'll talk about this on Monday. So we have our plantar fascia, and you can see how it connects from the calcaneus all the way up to the distal, to the metatarsal heads, and it keeps those two from separating. If you have uneven footwear, or if you have tight heel cords, or if you have, not uneven shoe wear, if you have shoes that aren't supportive, or you're walking a lot, where you're abnormally stretching this plantar fascia out, it can get irritated, and we're left with plantar fasciitis. So arch support has muscle support. Okay? It also has support coming from the ligaments, like we've already talked about. But the muscles, our posterior tib, our peroneus longus, and our intrinsic muscles. Okay? Our posterior tib, our tibialis posterior, flexor hallucis longus, and flexor digitorum longus. That's part of Tom, Dick, and Harry. Tibialis, hallucis, and digitorum longus. These span the ankle posterior on the medial side of the calcaneus. They pass under the cessum tali, and they give support to the medial side of the foot / arches. You could say / arches. It's a dynamic stabilizer of that medial longitudinal arch. And we also have the peroneus longus that starts lateral and goes up underneath the foot, and it goes and it inserts, as you will see when we start talking about muscles, it inserts onto the base of the foot, so it wraps up underneath, and that provides support to the transverse and longitudinal arches as well. And also the intrinsic muscles provide greater support versus our extrinsic muscles. Okay? So if our muscles are strong, we can take 15 to 20% of the total stress of the arches off. Okay? So our posterior tib, you can see the insertion of that as it wraps around our cessum tali. Okay? It's going to now come in and can dynamically stabilize. Okay? If you were to observe someone who has flat feet, Omar, I'm talking to you, big guy. Okay? If you were to observe someone who has flat feet and you try and palpate their posterior tib, they are going to light up like a Christmas tree. Okay? Because that posterior tib is doing everything it can to stabilize that arch, which isn't truly its main job. Its main job is to create some dorsiflexion. Okay? But it does dynamically stabilize the arch. Okay? Then there's your peroneus longus or fibularis longus, how it wraps laterally. It wraps around the whole base of the foot, and it will come in and inserts on the medial or on the kind of lateral aspect of the first metatarsal head. And so it's going to stabilize that transverse arch because it's wrapping around it. So just like with the hand, okay, we have our extrinsic and our intrinsic. Okay, so our extrinsic, we have our posterior group, or posterior superficial, our gastroc and soleus. Okay? Underneath those, or deep to those, we have our tibialis posterior. I say posterior tib, that's how I learned it. Our flexor digitorum longus, and our flexor hallucis longus. Okay? Arrow, arrow, Tom, Dick, and Harry. Okay? We have our anterior group of the extrinsic muscles. These are going to be our tibialis anterior, extensor hallucis longus, and our extensor digitorum longus. Remember, extrinsic means they create a movement in the foot without being in the foot. In our lateral group, we have our peroneus longus, peroneus brevis, and peroneus tertius. You will also see these called fibularis longus, brevis, and tertius. Okay, so right / fibularis out there as well. Our intrinsics located on plantar surface and layers. Okay, so exceptions are extensor digitorum brevis, extensor hallucis brevis, and our dorsal interossei. So our dorsal surface of our intrinsic muscles, we have our extensor digitorum brevis and our extensor hallucis brevis, brevis meaning short. On the plantar surface, in the first layer is most superficial, we have our abductor hallucis, our flexor digitorum brevis, our abductor digiti minimi. In our second layer, deep to that, we're going to have our quadratus plantae, our lumbricals, and then our third layer going to be our flexor hallucis brevis, adductor hallucis, flexor digiti minimi. In our even fourth layer, going to be our deepest layer, we're going to have our dorsal interossei, plantar interossei. All right, so muscle-wise, gastroc, okay? Two joint muscle going from our posterior femur down to our calcaneus tuberosity. Okay? Knee flexion and also plantar flexion, tibial nerve. Soleus lies deep to that, and its origin is on the posterior tibia and fibula, and it inserts same insertion along the Achilles tendon. Our plantaris is along with those two. However, our plantaris does cross both joints, but it is so small it's kind of insignificant. Our posterior tib originates on the interosseous membrane adjacent to the tibia and fibula, and then it goes down and inserts, wraps around the medial malleolus. This is kind of a hard picture. There's our calcaneus, and there's our cuboid, and then our proximal metatarsals. And so it wraps around the medial malleolus and goes and inserts on the navicular and most tarsals and metatarsals. So it has a wide sprain. Okay? It creates ankle inversion, and it also assists with plantar flexion as well. Okay? You can also write in / dynamically stabilizes longitudinal arch. Posterior tib, that's Tom. And our flexor hallucis longus, this originates on the posterior fibula, inserts on the distal phalanx of the great toe. Flexor hallucis longus flexes the great toe. Hallucis is our great toe. And it goes all the way down. And again, it's going to help stabilize our longitudinal arch as well. So it's also going to assist in inversion and plantar version. And then our last one, our Tom, Dick, and Harry. D is for Dick. Okay, it wraps around the medial malleolus and wraps around and goes down. And again, it helps to stabilize dynamically that longitudinal arch. Flexor digitorum, so it's going to flex our 4 lesser toes, and it's also going to assist in ankle inversion and plantar flexion. Moving on to the front, we have our tibialis anterior. Okay, so if you have in 150, if you stimulated the tibialis anterior to create dorsiflexion, okay, you're going to put a pad there and a pad there and get it to fire. Goes in and inserts it, wraps around the top of the ankle, and inserts on the medial side of the first cuneiform and first metatarsal. So it's going to create dorsiflexion, but it's also going to be our main ankle inverter. Our extensor hallucis longus is going to extend the great toe. Okay? in origins on the fibula. It's going to go out all the way to the distal phalanx of the great toe. And it's going to lift it up. Our extensor digitorum extends our rest of our digits, so our 4 lesser toes. So it's going to originate on the anterior side of the fibula in the interosseous membrane. Okay? It's going to extend the 4 lesser toes. All right, so our peroneus longus. This is attaches to the lateral proximal fibula, and it's going to go down around the lateral malleolus, go underneath the base of the foot, and insert on the plantar surface of the first cuneiform and metatarsal. So it's going to help to dynamically stabilize that transverse arch. So it's going to be main job is ankle eversion, but it's also because it wraps around and goes anterior. It's also going to help with plantar flexion. Then our peroneus brevis is going to attach more distal on the fibula. And it's still going to wrap around, but it's going to attach laterally on the base of the fifth metatarsal, that big knob and that kind of protrudes out from your lateral foot. And then tertius goes anterior to that lateral malleolus, and again, it still helps with ankle eversion. Okay. We're just going to breeze over this because I think that you can read it and you can you understand it. And this just breaks it down more. So most superficial, intermediate, most deep. Lateral view, most superficial. Okay. Most superficial. And then those are going to be the actions of our ankle prime movers. Okay, so our tibial nerve, we have pretty much 3 nerves that innervate our leg. And we have our tibial nerve, superficial peroneal nerve, and our deep peroneal nerve. So our tibial nerve does everything our posterior leg and plantar surface of the foot. Where our superficial peroneal nerve does our lateral side of the leg, and our deep peroneal nerve does our anterior leg, and our fibularis tertius or peroneus tertius. So moving on to the plantar surface. Okay. These are all the muscles that are listed. We're not going to get too much into these because we just don't deal with them all that much. Okay. I want you to see your flexor digitorum brevis, and then your adductor and flexor digiti minimi are going to be over here, and your flexor and your abductor hallucis are going to be over here. Okay. If we go deep to all of those, we see our lumbricals up top, and our flexor hallucis longus tendon as it's coming wrapping around, and our quadratus plantae goes in and inserts onto our flexor digitorum longus tendon to help stabilize the arch of the foot. Okay, so a lot of these, especially these 2 long tendons, this flexor digitorum longus and our flexor hallucis longus, help to dynamically stabilize that longitudinal arch. And don't think I'm gonna you just don't need to know these. Know what the terms are because you might see them, but I'm not gonna ask you specific questions on an exam of where's the insertion of the adductor digiti minimi. It's just not gonna happen. All right. So moving into common ankle pathologies. Okay, we got a lot of them. All right, so let's dive in. So our shin splints. If you've ran a lot before, okay, or if you're just now starting to run in your quarantined state of psychosis because you need to get out of the house, okay, it's happened to me. Okay, you're gonna get shin splints initially. Okay, especially if you land hard on your heel, and then your foot, and you have to keep your foot from slapping down. Okay, it's called exercise-induced pain on the medial edge of the tibia, usually a few inches above the ankle midway up the tibia. Inflammation of the periosteum because there's an overuse. Okay, there's an overuse injury that can result from running on hard surfaces running on tiptoes, and playing sports that involve a lot of jumping. Okay? So if we are on the posterior side of the medial edge of the tibia, and it is a muscle that is involved with stabilizing the arch and helping with dorsiflexion, what muscle is that? Okay? Flexor hallucis longus and posterior tib. Okay? You can even have, that's posterior shin splints. You can even have anterior shin splints on the anterior side from an inflammation or an overuse of your anterior tib. Okay? If you've ever tried to rub them out, you can rub them out because those muscles just get sore and they need to be kind of a deep massage. In class, I may ask our massage therapist in the house what they suggest to do for their massage of their shin splints. Medial tibial stress syndrome, where we have anterior leg pain not associated with a fracture, and it can just be another term that's used for shin splints. Medial tibial stress syndrome. Okay. So plantar grade is a normal description of a normal foot, where the sole of the foot is at a right angle to the leg when a person is standing. Okay. So that's plantar grade. That's normal alignment in stance phase, kind of mid-stance phase, right angle to the foot. Okay. A equinus foot is when you have a super high foot or a super high arch. So you have a high arch and then a MTP extension and IP flexion of the great toe. Okay, so think of that metatarsal is coming straight down there, and then it's going to kind of go into a sharp angle of extension on your MTP. Okay, this is where the hind foot is fixed in a plantar flexion, and there's no active dorsiflexion available. Okay, so it's like someone is walking on their tiptoes at all times. The flip side of that is the calcaneus foot, which is a foot that is fixed in dorsiflexion. Just due to these two things are usually genetic. You're not going to usually get these two things from immobilization or anything like that. Okay. A pes cavus is a foot that has an abnormally high arch. Okay. You can see that if this foot was on the ground, you would be able to drive a truck through that arch. It's a very, very high arch. And again, same with equinus foot, you're going to have a steep extension moment of that MTP. Our pes planus is a flat foot, and that's not even a bad one. So there's your naviculum and your talus. I've seen it where that thing is just compressed down the ground. Okay. Loss of the medial longitudinal arch. We have our hallux valgus, which is caused by pathological changes in which the great toe develops a valgus deformity, and that's, you can see that. Hallucis longus. So there's the other feet, the other toes are kind of in a normal alignment, right? So it's not like this is RA where you get an ulnar drift or a lateral drift of all the toes. It is just the great toe. And the distal end points laterally, and that's what it looks like on X-ray. Okay? The whole metatarsal shifts out, and then in order to maintain its alignment, that proximal phalange has to shift medially. Hallus rigidus. This is a degenerative condition of the first MTP joint and pain and diminished range of motion. Where that your amount of flexion and extension of your great toe is not going to be the greatest. Okay? Where there is you can see how there's a joint line, and plenty of joint space. See how there's no joint space there. It's kind of like a degenerative OA. Hammer toe is where the PIP is flexed and the DIP is extended, especially like with that one. So you have a great flexion of the PIP, and then that DIP is extended so that toe can still sit flat. Mallet toe is extension of the PIP, like in this picture, but then flexion of the DIP. You have hammer toe, mallet toe. And then a claw toe, which is flexed PIP joint and flexed DI point, B point, where kind of it just looks like they're all just flexed. Okay? Now it is of note, in order for those two things to happen and not kind of wrap underneath the foot, you do have to have MTP extension within those joints. Okay? Metatarsalgia, pain around the metatarsal heads. This kind of feels like they're bruised or like walking on pebbles. Pain increases with activity. What you can do if you have a patient who is doing this, they make our metatarsal bars, okay, that you can put into shoes. You can get them at Target, that you can put in there. It's going to give those areas a little bit of a break. Okay, you may also send them to our good friend at Todd Ank at Reliable, and he'll put like a metatarsal pad in there that will help take pressure off of it as well. A Morton's neuroma is an abnormal pressure on the plantar digital nerves, commonly at the web space between the third and fourth metatarsals, where there's an inflammation and a swelling of the nerve. Okay? It results in pain and numbness in the toe area and gets worse with any activity such as running. Okay? So this is where you can have, like if you wear too narrow shoes, you can develop Morton's neuroma, because as you land, right, as you land, your toes splay out. That's why like Reebok shoes have a really good toe box, and you hear that a lot with really good like shoes that have a really good toe box, because that foot can land, the toes spread out, and then they can move off. But if you wear too narrow shoes, your toes can't expand, and they may compress that nerve and irritate it. Okay? So turf toe is a forced hyperextension of the great toe at the MTP joint, commonly seen in football, baseball, or soccer players. Anything where you have people who are kind of putting their foot into turf with cleats, and those cleats can kind of get stuck. Ankle sprains is one of the most frequently injured joints in the body, most common injury among recreational and competitive athletes. And lateral ligaments are the most frequently injured. We talked about it before because there's only those 3 little tiny ligaments that help stabilize that lateral ankle. Okay. Lateral or inversion sprains, where those toes go in and kind of wrap around, occur when the foot lands in a plantar flex in inverted position, and then it just kind of rolls over because of that lack of stability. Okay. One or more of the 3 lateral ligaments may be stretched or torn, and this follows the grades 1 through 3, where a grade 3 or a grade 1, okay, where grade 1 is just a few tears, grade 2 is a moderate amount of tears, and grade 3 is a full rupture. That is a medial ankle sprain, okay, where he sprained the deltoid ligament, or it could result in a medial ligament deltoid sprain. Because his foot is going eversion. It's an eversion ankle sprain. This is an inversion ankle sprain. His face is not too happy with that. An ankle fracture occurs when a person trips over an unexpected obstacle or falls from a great height, and usually involves a twisting component to the ankle. You see this a lot in the wintertime with ice. Okay? Especially people who don't have good balance, good strength, good proprioception, or good vestibular. Okay? They hit a piece of ice, and all of a sudden, their leg shoots out from underneath them. They might land on them, and they may fracture their ankle. Okay? The lateral malleolus is most commonly involved. Okay? There's 2 videos that you can see. And then this is an ankle fracture. Okay? And this is the danger when athletes wear these high ankle braces without any pathological issues with an ankle. You run the risk of now fracturing your tib fib. Now, granted, a fracture is going to heal a lot better than an ankle sprain. Okay? Not saying that he'll be playing later on the season that this happened, but those bones are going to heal a lot faster than the ligaments would if the ligaments got sprained. We were nice to have an anterior view and a posterior view. Not supposed to be like that. A bimalleolar fracture involves both malleoli, both lateral and medial. You can see that there's our lateral malleolar fracture there, and our medial malleolar fracture there. And our trimalleolar fracture is where we have 3 malleoli. Now, I know we've only talked about 2, okay, so there's our medial, there's our lateral, but you also have a trimalleolar fracture back in there that also is our 3rd malleolus on the back of the tibia that can also be fractured. Okay. Plantar fasciitis is a common overuse injury. With most common report is pain in the heel, but the pain is usually located kind of throughout it, but mostly you can kind of put your thumb up underneath, and we can do this in lab, up underneath right where the plantar fascia attaches into the calcaneus. You can pretty usually push there, and it hurts pretty bad. Okay. Achilles tendonitis is inflammation of the Achilles tendon, and it can be a precursor to a rupture. We'll get to that in a second. And then you can have a nope. I'll have to look at it before I tell you what it is. I'll look at that and tell you what that deformity is called. An Achilles tendon rupture, the complete rupture where the person is unable to plantar flex the foot, that is called Thompson's test. Okay, so if I have someone come in and our main report is not able to flex or point my toes, I'm going to do a Thompson test. I'm going to test the integrity of that structure, that mechanism. Okay? This YouTube video is a picture of Dancing with the Stars. I forget what her name. She was an Olympic volleyball player who was on it 5 years ago. And during her dance rehearsal, her dress rehearsal, she popped her Achilles tendon. You can hear it. It's pretty crazy. Lots of people have popped their Achilles tendon. Kobe Bryant is one of them. Okay. Brandon Phillips did it as well. And it's a very, very, very hard injury to come back from, especially if you're like a police officer, fireman, professional athlete, because there's no grafting with this. When we replace an ACL, okay, or a PCL or MCL or whatever, right, or a UCL in our elbow, we can graft tendons. We can't graft tendons to support that structure. Okay, so they have to stitch that tendon back together, and it takes a very long time to heal. During that time, that calf and that gastroc and that soleus compress down to nothing. They atrophy down to nothing. And so you have to get the strength back. And that's the biggest thing. You have to get strength and mobility back, and it's just very, very challenging. Better part of 12 months. It probably took Kobe a better part of 12 months to get back. My police officers don't return to duty until usually 12 months. Triple arthrodesis. Arthrodesis means a fusion, where they fuse the talocalcaneal, the talocalcaneal-cuboidal, and the talonavicular joints. It provides medial lateral stability of the foot and relieves pain at the subtalar joint. Okay. This means that the inversion and eversion of the ankle are lost, where plantar flexion and dorsiflexion are remain intact, because that is the tibiofemoral joint. The tibia. We'll get there. There it is. Okay, so there's our triple arthrodesis. The subtalar joint, the calcaneal-cuboidal, and the talonavicular joint are all fused with pins. Okay, and that's not so bad, because we still have dorsiflexion and plantar flexion. If the joint of the ankle joint itself is degenerated, the new thing that's coming out is a total ankle replacement. When I was in practice 5 years ago, I had seen like 3 of them. Okay, in the past 5 years, the surgical procedures have gotten more refined. The prosthetics have gotten more refined, and it's my understanding that these are becoming a little bit more common. They usually just fuse them. Okay. Points to remember: stretching is performed on relaxed muscles, and strengthening occurs when muscles contract. And we already know these. Okay. All right. So that is it for ankle and foot joint lecture. Again, if you have any questions, be sure to write them down, and we will talk about any questions or anything that we need to express more upon or do more things on in lab on Monday. All right. I'll see y'all then.